going to go ahead and get started here. Welcome to a fun afternoon of hearing from the experts. My name is Eric Vaughn. I'm the Chief Commercial Officer at MST, and it is my privilege to introduce a couple of dear friends of MST and dear friends of mine. Closest to me, we have Dr. Brandon Ayres with Wills Eye Hospital, and we have Dr. Nicole Fram from Advanced Vision Care in Los Angeles. These are the battle of the complex cases between these two. They're going to show some really interesting things today. So without further ado, I'll turn it over to our speakers. Thank you both.
All right, well, thanks. Thanks for coming. Thanks for having us, and thanks for the invite. So what we thought we would do today, again, I'm Brandon Ayres, this is Nicole Fram, was just show, a series of cases that really highlight some of the complex cases that we have to tackle and try and break them down into their individual parts so we can make these complex cases not so complex and not so scary, and also show some of the specialized tools that we can use that helps us get through these cases. So this is really going to be a choose your own adventure, and basically we can go back and forth and we can show any case that you guys would like. But I thought that a few cases that we could show that first really shows off some technique and some instrumentation is really zonulopathy. One of the cases that puts fear into the hearts of almost any anterior segment surgeon. So I'll go ahead and choose zonulopathy. And the first case is going to be a case of mine, so I'll let this run. And Nicole, feel free to stop me anytime you think I've done something stupid. This is a case I did just for you, and notice I've got the eyelashes out of the way.
I'm really happy about that.
Nicole, when you see her videos, her eyelashes are tucked away and mine tend to be all over the place, but not this time, I've learned. So this is not a subtle zonulopathy. This is a very clear zonulopathy case. And whenever you know a case like this is coming up, you've got to have your instruments ready. So before I even go to the operating room, I'm already going to the drawer on the 7th floor at Wills Eye Hospital. I'm getting all the stuff that I need. We know we're going to need capsule retractors. If we need capsule retractors, we're going to need capsular tension rings. If we're going to need capsular tension rings, we might need segments. We're going to need suture. Have everything in the room that you think you may need. Have more than you think you may need. These cases can already take a little extra time, and the less time the scrub tech or the nurse has to run around to get your instruments, the better.
Here I'm showing how you want it when you're going in. This is a 1.0 Alcon blade. When you're going in to make that pass, it's under the iris but over the capsule. So you need to make space with viscoelastic for that area. Here we're going to also use Ahmed segments, and we have very similar techniques because he taught me a lot of what I know. And so there I am putting viscoelastic, and then I get this nice pass. Those are the MST Snyder graspers, and then we have the 23 gauge serrated so we can keep it separate. 23 gauge serrated holds the suture a little bit better when you're putting it in. So now, we load everything in. I don't like needles in the eye, so I like this needleless recovery technique. And then you can either use micro forceps, or you can do it with a Sinski where they have these little fixation holes. And what you're doing is you're putting this portion of the ring inside, and then the loop-de-loop is in the sulcus on top of the capsule, just like we showed. And the titration of this is actually the hardest part. So in the interest of time, we can't show all of that, but don't tighten your sutures completely before you put your IOL in. Because if everything's on really like a lot of tension and you put the IOL in, it can sometimes split the anterior capsule. Ask me how I know. So you really want to keep it a little loose. And this is the example of grabbing the knot and literally shoving it in. Then you cut, then you grab those ends and you feel a pop. Like you'll definitely feel it going in. And sometimes I close that with a 10-0 nylon if it's a 10-0 Vicryl or 10-0 nylon if it's leaking. I put triamcinolone in at the end of the case, washed Kenalog. And then you want to see if there's any vitreous coming forward. And fortunately, we got away with it. But the two indications to say I'm going to use the Ahmed segments or a fixation ring is if it doesn't center after you put your CTR in, or if you have diffuse kind of zonulopathy over time that can cause an UGG or high pressure or pigment dispersion.
The key is always know what the lens is, know the what I call the pinch points of the lens. Is it going to be at the haptic optic junction? Is it a 3-piece where I don't worry as much? Is it an Alcon platform? Is it a B&L platform? They all have their own personality. But if you can't see it, it doesn't make a difference. It's going to be even more challenging. So you've got hooks versus rings to dilate the pupil. As long as if your pharmacologic dilators haven't worked, in this case they haven't. I like to preserve the anterior chamber because we're going to be moving parts from the bag to the anterior chamber. So hooks here don't really work that well. So we're going to go for a Malyugan ring. And I think a 625 for me is probably big enough, but I think a 7 would be fine. Do you have a preference yourself,
I
Nicole?
usually use a 625 because I worry sometimes about the iris as I'm putting it in.
Yeah. And you guys can see this is not a huge eye. I think if I tried to put a 7mm in there, it doesn't sound that different, 625 to 7, but it makes a difference. It makes a difference.
Every millimeter counts.
So the key is dissecting those haptics out of the capsular bag. And this bag actually opened up remarkably well. So I thought this is going to be a home run, no problem. But for whatever reason, the distal haptics were really stuck, even though that looks like a nicely polished lens. So we finally worked hard enough with a few vials of OVD to get one haptic freed, but I can't get the other one free.
What type of OVD did you use?
I'm probably using, and it really depends, either Amvisc or a combination of Viscoat and Provisc. So often I'm using Provisc for this portion. So with a small eye, a ring, we need to make more space. I'm just making myself frustrated. We're putting more OVD in. Just by amputating one of the haptics, which we already had free, now we've got more room to move that IOL around, okay?
So
Still
did
trying.
you use a 19 gauge to cut that optic haptic junction?
That was the, yeah, that was the
because you can also use a
packaging.
23 gauge.
Yep.
Yeah.
So for cutting a haptic, it's a good point. You can use the horizontal scissor, the smaller scissor, but I already had the IOL scissor out, so I just went ahead and used it. So I still can't free up that other haptic, and I don't know why. But I know that I'm having a hard time seeing it. So we're gonna go ahead, and I've got the optic elevated, just the haptic is still stuck in the bag, and I love to cut lenses.
How
Watch any of my
many
videos.
pieces can Brandon cut?
I cut it into a million pieces because I don't like to stress the wound. I like that wound to be nice and calm, so I'll cut them into 3 or 4 pieces. I just find it enjoyable, and it's fun. But now I've got a lot more space in that anterior chamber. I can manipulate that lens, and now using a bimanual technique, I can sort of pull on the lens, get the cannula down along the haptic, and we can free up probably that terminal portion. And this is not this is an Alcon lens, it would make sense, but that's a J&J platform lens. That's not usually where I have the challenge.
This is where the pain point usually
That's
is.
usually where it is.
At the notch. And then on the Alcon lens, it's usually at the terminal bulb.
So, could I have left the haptic in there? I could have. There's probably enough room for a second lens, but I like to get everything out if I can. So just by being a little bit creative, using some extra tools, using some extra OVD, making room in the eye, you can use a bimanual technique to get the haptics completely out. And time after time, we are using bimanual techniques to help us get these lenses out. Even in cases where our lenses have been in 5, 6, 7, 15 years.
Right. The concept of amputating the haptics to get the bulk of the optic out, then you can kind of go down the optic haptic junction or the junction and make room and do a bimanual technique or stripping of the haptic out. It preserves the zonule and it gives you so much clarity there. So this is a patient. So we talked about the terminal bulb of the Acrosop, and then we talked about the notch of the Technis. Well, this is the MX60, and it basically goes in everywhere in that eyelid, and it's really something. So this is, I'd like to do a pars plana assisted anterior vitrectomy when I have an open posterior capsule. This is a cannula I'm working on, the Framula. Yes. It's beveled down now, and it has kind of a Donnenfeld-like tip to it, so you can dissect and get under, and then the viscoelastic goes in the direction. Stay tuned, it's still in progress. So what I'm doing now is trying to get a feel for the lens. Like, what is this going to do? How locked in is this? Patient is 7 years out with positive dysphotopsia, really unhappy. So I like to use capsule retractors during these cases in order to allow me to use a bimanual technique to dissect, especially with the MX60. So now I have a bimanual ability to go in and hold and dissect and not have to worry about that zonule and holding that capsule back. So you see how I'm using 2 hands to strip it away. And I could do that with microforceps as well. So these capsule retractors, they definitely get in the way as you're elevating. But if you can just use them to loosen things up and then take them out.
So it gives you a third hand.
A third hand,
yeah.
Yeah, so who knew? So I found yet another use for the capsule retractors. So here we're going to do the same thing on the other side. You may say, and a lot of people say, your lens can't come out because it's too dangerous. In the right hands, with the right technique, in our hands, we published on this and showed that closed bag-to-bag exchange versus open posterior capsule bag-to-bag exchange carried the same risk in experienced hands. So we obviously don't want to cause any retinal tears or detachments, and we have the patients see their doctor. I use a different, heavier, this is a 27 diopter lens, so I use a heavier scissors there. And now I'm doing my pars plana assisted anterior vitrectomy. We're gonna put in triamcinolone.
So, Nicole, you didn't extend the posterior tear at all.
No, I didn't.
Not at all, so you could.
But I think it was because there was so much control and not so much viscoelastic pushing everything back. Now I'm using the vitrector because I want to make about a 4.5 millimeter opening in that posterior capsule. I'm using washed Kenalog because when you're trying to do an optic capture procedure, you have the haptics in the sulcus and the optic behind either the anterior or the posterior or both capsules, right? So that's what stabilizes it. So I'm spending my time doing a nice vitrectomy here. And then we're gonna put in, see, I already expand to 3.0 because I'm using the LI61AO. So just cutting it into 2 pieces is just fine with me. And then we bring this into the sulcus first. And I wanna show you, I mean, we all show these videos of optic capture where you just like pop it back and it looks perfect, and isn't that awesome? But it's kind of difficult. It's kind of like a sneak and tuck.
Yeah.
What's your technique with optic capture?
So sometimes it actually matters where you have the lens rotated.
Okay.
You may have an oblong capsule
Yeah,
rectus,
so
so I like to tuck into the long curve, if you will, of the ovalized rectus.
Okay.
And I will typically tuck the distal portion of the IOL under,
Right.
advance, and push.
Exactly.
Or if it's vice versa, you would dip towards you. You have
Towards
to
you.
really retract, tuck it under, and let go.
So here I couldn't get it in, so I had to go back in and make the posterior capsule a little bit bigger. So you can use the vitrector to do that as long as it's fibrosed and not a dead bag. You do not want to do these maneuvers of optic capture with a dead bag.
Yeah, here. So you're pulling back towards you, correct?
Exactly.
And we'll dip down.
Exactly. So, but I think that sometimes, so it's really just like a sneak, push it all the way over.
Yeah.
Then you do the other side. So optic capture is a great way to have a really nice positioning after surgery without the need for sutures. And then they have a much less rate of CME. This side, we're tucking that under and making sure we have nice stability. And these haptics need to be in a portion where there's good zonules, right? So if you have a portion where there's like iffy zonules, don't put the optic haptic junction there. And then I have lots of problems with OCD, so I check all my incisions with Sidel testing.
And once again, notice the beautifully draped
There
lashes.
are no eyelashes.
There are no eyelashes.
These are not eyelashes. This is the other thing. So sometimes I block and like they're like looking down. A lot of times we're doing fixation techniques or doing LRIs like it showed at the beginning of the case. You need to get the eye in a centered position when you're doing these cases. So it's okay. This is a 6.0 silk on a G6 needle, and you just kind of go an episcleral bite and use a hemostat, and that keeps the eye in a nice position.
All right, well, Nicole, we've hit just after 1:30. I know we have speakers who are coming behind us, so we really shouldn't take up too much more of their time.
Any relationship between the size of the open capsule and the size of the
So Nicole, so the question was, if it didn't come through, was any relationship between the optic size and the size of the
It's a great question.
rectus?
The optic is, with this lens, is 6 millimeters. So you want your capsule opening no more than 5, right, to get good coverage. Sometimes we do like 4.5 by 5. But if it's bigger than that, it's not gonna stay in that position, right? So what's your plan B? Put in the sulcus, suture it gently to the iris so that it doesn't move over time. Plan C, take everything out, do intrascleral haptic fixation.
Yeah, always have multiple plans.
Yeah. All right, great. Well, Brandon, we did it again.
It's been fun. Yeah.
Thank you.
Thank you guys so much for coming. Again, I'm Brandon Ayres, Nicole Fram. We appreciate your time.
And
we got to respect.
Thank you to MST.
And thank you, MST.
For giving us all these instruments to play with. Great.